Just going to talk about pleural infection. Now, just as a sort of disclaimer, it's something I've got a real passion for, so I sometimes rabbit on for a while, so I'll try and keep it brief. But if you can imagine, pleural infection for a lot of people is a bit like pneumonia plus almost. So usually patients will get a pneumonia, they'll then get a little bit better, and in hospital they'll start then to feel a little bit worse. They develop chest pain, the shortness of breath gets a bit worse, the temperature gets a little bit worse. And so you think, oh, what's going on? You do a chest x-ray and lo and behold, some fluid has built up in the space between the lung and the chest wall. That's a pleural effusion. And then if patients are unlucky enough, that fluid itself becomes infected, and that's pleural infection. And I'll go into that in a bit more detail, but that's essentially what happens in my life's passion of pleural infection. Now, it is a disease, I always start with this slide, so sorry Charlotte, you may well have seen this before, but it just goes to show that pleural infection is a disease of some real heritage. I said I wouldn't move around, but I always move around, so sorry about that. It was first described by the ancient Egyptians, presumably some sort of hieroglyphics on a wall, but they were describing probably empyema necessitans, where the infection was actually burrowing its way from the chest through the chest wall and then sort of popped like a sort of cyst. And then Hippocrates, as he often does, really professionalized the whole diagnostic and treatment process. So he said that if you sort of sliced into a patient and if the stuff that came out was pure and white, the patient tended to do okay. If it was bloody and fetid, a great word, then they tended to die. He said that if you shook the patient vigorously by the shoulders, you could work out the character of the fluid within. And that was succussion. And then finally, the most sort of brilliantly was the sign of damp earth. So a bit like a sort of ancient PET scan, where they would just smear wet mud on a patient's hemithorax, and then the area that dried the quickest was felt to be the most metabolically active, and therefore, presumably after some cleaning, where the sort of lancet was stuck to drain the fluid. It's fair to say that nothing really moved on for the next few millennia, or if anything regressed. So by the time Jupiter, the famous physician, got his pleural infection, he said he'd rather die at the hands of God than with the help of a surgeon, which was really how we treated pleural infection at the time. War, as it often does, not only advanced technology but also advanced treatment in medicine, and especially for empyema. The Spanish flu was ravaging US Army camps on the aftermath of the First World War, and these poor chaps were getting absolutely sliced apart by the surgeons to treat this pleural infection that was developing after Spanish flu. The mortality rate would range from something like sort of 90% to 95%. So even the most enthusiastic surgeon was probably thinking, oh, maybe we're not doing quite the right thing here. And by augmenting their approach by using a more sort of a more conservative drainage strategy, they reduced it down to 5% after the Empyema Commission was set up. Now, Professor Light is probably the godfather of pleural medicine, and we're kind of coming into modern day here, where he initially sort of did some early diagnostics and showed that the more acidic the fluid, the more likely it was the patient was going to go on to need some sort of procedure. We've come a long way since then, but probably pleural infection is still a little bit behind a lot of the other respiratory and cardiovascular conditions we study. We have some idea of how the bug gets into the pleural space, so most likely it's through consolidated lung and translocates across the visceral pleura. But it can come from the other way, so you can imagine that lung cancer or post-operatively, some come from the visceral pleural defects. It can hematologically spread as well, and I think that's mostly overlooked. We see patients a lot who've got no evidence of pneumonia whatsoever and then just develop pleural infections, sometimes after having a dental procedure. And then you can imagine abdominal spread from an infected ascites, spread from the mediastinum, or penetrating injury. Now, once the bacteria is in the pleural space, we do have a better idea of what's going on. You get a huge inflammatory cascade developing. It's an incredibly inflammatory condition. CRPs are kind of off the scale, neutrophil recruitment off the scale in pleural infection. That increases pleural fluid accumulation, and you might get a simple parapneumonic effusion. In fact, around about 50% of patients that we see in hospital with pneumonia, if you put an ultrasound scan on, about 50% of them are likely to have some degree of pleural fluid there. And I always tell my patients, you know, imagine if you've got an infected leg, it's going to swell up. The same thing happens in the lung. However, as I said, some patients get unlucky and bacteria start to replicate within that fluid. And if that happens, the pH of the fluid is driven down as lactic acid is produced, the glucose is driven down, and fibrinolysis, which is happening in our pleural fluid all the time, starts to get dysregulated. And you go from having a simple pleural effusion, so just like water in the bottom of a glass, becomes almost honeycombed, complex, and very much more difficult to drain for antibiotics to penetrate and for us to treat. This is the incidence of pleural infection. So this is just NHS digital data that we looked at a few years ago. And you can see that the incidence is rising and rising and rising in the elderly. I don't really know why that is. Is it because we're picking it up better with more CT scans? Is it people living longer? All possible. But the mortality rate is static around about 10%. So this is a serious condition if you're admitted to hospital with it. And the length of stay is around about 14 days. It's a lot of burden. We'll often have 2 or 3 patients on the ward with pleural infection at any one time. I don't think it is just pneumonia. Pneumonia has a much greater average age in hospital and doesn't have this male predominance. And I can't really explain that male predominance to you. We could be a little bit lazier and say that men are less likely to go to their doctor early, so maybe they're more likely to develop pleural infection, not get their antibiotics. Are their teeth a little bit worse? Do they drink a little bit more alcohol? All risk factors for pleural infection, but I think there's probably something more to it. We linked this HES data with Public Health England data on flu and found that flu spikes often were followed by a spike of empyema as well. But interestingly, chronic respiratory diseases such as like COPD, ILD are not linked with empyema or pleural infection and are actually protective for it. So is that because patients are getting antibiotics earlier in those conditions or because they're getting steroids earlier? I don't know. What are the bugs that are causing pleural infection? Well, they're not really the bugs that cause pneumonia. This is a nice review by Hassan, a doctor from Oxford, who did a systematic review of all the papers that had looked at microbiological yield and found that Staph aureus is the most commonly grown. It was pneumococci in the tropics, most likely because of HIV. But in our sort of temperate region, it's most likely a strep viridans. So it's called strep viridans because it stains green on an agar plate. But it's not a typical bug for causing pneumonia. So it is again, a slight mystery of pleural infection as to why that is the predominant agent. Another thing he found was that the yield was not brilliant. Now, he quoted it as 52%. So the idea that you'd send frank pus off to the lab, and yet the yield was only come back as 50%, and it's nowhere near this in real life. It's more around about 20%. We just don't grow the bugs particularly well in the lab. And what can we do about this? Well, you can either send it off in back-tech bottles. Now, I don't know how many of physicians in the audience, but just sending it off in blood culture bottles really kicks your yield up. You can do a little bit more fancy. So Nick Kalidis has just published the TORPID study, which did 16 sRNA, and on the pilot study, which is a large observational study of pleural infection, and found that actually almost 80% of these cases, maybe 16S is a little bit too sensitive, but 80% of cases are polymicrobial. So you're finding more than one bug down there. If it was going to be monomicrobial, it was most likely to be a strep pneumoniae. So it's like a zoo down there, basically. And is that really useful as a clinical tool? Probably not, because it's not going to help you to narrow down your antibiotic choices, but it's very interesting from a scientific point of view. And then finally, another nice study from Oxford is the audio study, where at the same time as putting in a chest strain for pleural infection, they also did a biopsy, and they sent that biopsy off to the lab. So instead of just sending the fluid, the pus, they sent the biopsy sample as well. And they found that it's massively increased their yield. So you had blood cultures, which you're likely to get a hit in around about 10%. The pleural fluid around about 20–25%, which is what I think we see in clinical practice. And then if you send off the biopsy, it's more like 50%. I wouldn't do routine biopsies in patients with pleural infection, but actually I think it's useful because it shows us actually these bugs are hanging out in the pleura, where there's good blood supply, where there's good oxygenation, not just freely floating in this sort of nasty, pussy fluid. In terms of antibiotic choice, now in Bristol we've got an amazing pharmacokinetics lab, and as part of my PhD, what we did was we did serial sampling of patients with pleural infection. So when a chest drain was put in to drain the fluid, we took blood and pleural fluid samples and timed that with antibiotic administration, just to see. The fear from physicians was that these complicated parapneumonic effusions, the antibiotics probably wasn't getting in there. It wasn't really based on anything in particular, apart from a small study in white rabbits from New Zealand. So we wanted to say, is this really true? Is it right that the antibiotics aren't getting there? Because it made no real sense to us. So we looked at lots of antibiotics really, but the sort of headlines were that in the antibiotics we use commonly, there is no real difference between the pleural and the sort of blood penetration at all. In fact, the sort of the profile for pleural fluid is actually optimized. If you look at piperacillin, so piperacillin, tazobactam, tazocin, one of the antibiotics we hand out like Smarties in North Bristol, the profile, the dosing profile is actually much, much better in the solid line of pleural fluid compared to the profile in serum. The only thing we found was cotrimoxazole, which we often use to treat pneumonia. The trimethoprim does not get into the pleural fluid for whatever reason. And so we've taken that off our formulary for patients who come in with pneumonia with any sort of pleural effusion at all. How long should we give the antibiotics for? Now that's really as how long as a piece of string at the moment. The guidelines say 4 to 6 weeks, based on nothing really, apart from it's just a nasty infection, so let's give it for longer. 2 studies have tried to answer the question, but unfortunately just a bit too small at the moment, with 50 patients in each, to answer a question that probably requires 1,000 or so, given the event rate for treatment failure is actually quite low. In terms of the diagnosis and definition, I suppose this is important. When does a simple parapneumonic effusion become a pleural infection or become an empyema? Well, an empyema, in its sort of historical sense, is basically pus from the pleural space. So it comes out and it's pussy, or it smells, or something like that. I've had one patient when I did the incision. It came out, it absolutely stank, and she said, "Gosh, is someone eating a Chinese?" It's like, well, you need to change your takeaway, because it did not smell anything like that at all. It can really stink, but that's a frank empyema. Or if you grow something, then that defines an empyema as well. However, as we know, we don't often grow something. It doesn't always look that bad, so we use pH as a good proxy for pleural infection. But you can see, this is how things and dogma gets ingrained into medical practice, is that there was Professor Light, our godfather, in 1980, did a retrospective analysis of just 26 patients. And he found that actually, pH less than 7.2, taken from the pleural fluid, they were likely to go on to need a chest drain. But even he said in his paper at the time, take that with a pinch of salt. However, then everybody started doing it. All the prospective studies are using the same cutoff. So by the time you meta-analyze it 15 years later, of course, the ROC curve is going to look brilliant. But that's because everyone's now using that cutoff. And it's impossible for us to drag our way from that cutoff now. And it's never been prospectively analysed. So what can we do? So there are other pleural fluid biomarkers out there that we have tried. In Bristol, we looked at SUPAR, soluble urokinase activating receptor. And in Oxford, Dr. Badawi looked at PI1. Both of us really trying to move the field forward and say, can we try and move away from pleural fluid pH? Because the problem with pH is that it doesn't tell you whether the patient's going to go on to need a chest drain, surgery particularly well. It doesn't proxy very well for ultrasound findings. So pleural fluid SUPAR, we looked at it was a retrospective study of all the patients that we had in our freezers. We did SUPAR on them, and we found it was actually performed a lot better than a lot of our currently used biomarkers in terms of the requirement for surgery and also for needing a chest drain as well. At the moment, just a research tool. And actually, Ehab Badawi, he probably went a step further, because what's really difficult is actually prognosticating these people at the front door. They get to pleural infection, you've got no idea how aggressively to treat them, you don't know what their mortality is. And PI1 was actually able to tell the difference between patients' length of stay and also survival, independent of all other biomarkers and radiological findings that we have at the moment. These are our pleural infection guidelines that have just come out from the British Thoracic Society. I throw them up there just because they're just out there, more of a plug really. But again, we're still anchored to pH. There's a little bit of a shift away because we've now got this intermediate group, but we still use 7.2 as high risk for complex pneumonic effusion or pleural infection inserted chest drain. I don't think everyone needs a chest drain. You'll often see young men come in, they're in their 20s and 30s, they've never been to hospital before, they get pleural infection. You put a chest drain in and they're in for weeks because there is a huge amount of clinician stasis once a chest drain goes in. No one really wants to take it out. Are we sure we're definitely going to take it out? The patient stops moving from the bedside because they've got this slightly sore drain in with a little bucket on the floor. It's a bit like a ball and chain, really. They don't really want to move, and so that and they become really institutionalized. So we're currently just about to open a study in Bristol looking at a slightly more conservative method of draining the fluid. What we're going to do is we're going to randomize, and hopefully Cambridge will be taking part in this, we're going to randomize patients to receive the current standard of care, which is a chest drain, versus what's called a therapeutic aspiration or therapeutic thoracentesis, where we just take the fluid off in one go, take as much as we can, and then put a bandage over the top. And the hypothesis is that that will reduce hospital length of stay, which will be the first powered study of its type asking that question. So if you put in a chest drain or you've done a thoracentesis and that fails, well, what's the plan next? Well, we're pretty simplistic, I'm afraid, in pleural medicine. The first, what we've done is also we could stick in a bit of salty water. So my boss, Professor Maskell, he did this study where he just put lots of fluid in, so around about nearly a litre a day, 250, 3 times a day, drained into this chap who looks not particularly thrilled about it. And basically just washing out the pleural space. It's only been tested once, but it seemed to suggest that patients had a reduced need for surgery. But it was a single centre study where the clinician who was running the trial made the decision around surgery. So definitely some confounders there. We used to use streptokinase. So basically the idea of a clot buster that was put into the chest to try and break down some of that honeycombing that I talked about earlier. This is the largest trial that's ever taken place in pleural infection. 454 patients testing the standard care against placebo. And the standard of care was absolutely negative. It did nothing to reduce mortality or length of stay in these patients. A massive finding at the time. Feels slightly embarrassing coming to this incredible place where you're doing incredible science. And then, this is what I'm presenting as the sort of cutting edge of pleural infection research. But this is a viscometer. So essentially you take a patient's pleural fluid and you test how quickly it drips through the needle, and high-tech sort of stuff. But what they found was that if you took your clot buster and you added DNAs, it dripped through a lot faster. So the feeling being you can't just break down the septations, you also have to make the fluid a little bit less thick as well. And so again, Nick and Naj did a study called MISS-2, where they tested DNAs versus the clot buster in combination. So they tested placebo, clot buster by itself, DNAs by itself, and then the two together. And you can see that the change in pleural fluid on the chest X-ray did significantly reduce, with some positive secondary outcomes as well. So that is now our new standard of care. When to do surgery? Well, around about 10 to 15% of these patients go on to need surgery, depending on the sort of centre you're in. If you go to a surgical centre, you're more likely to get surgery. Go to a barber, you get a haircut. But if you're going to do surgery, more conservative the better. And in Oxford, they've run the MISS-3 trial, which is a feasibility study randomising patients to receive either standard of care, which will be a chest drain, early surgical opinion, or early intrapleural therapy that I've just talked about. That was, even though running COVID, they did an incredible job. They randomised that number of patients. It seems to be a feasible study, and so they've just got the money to do it on a grand scale. It's going to be around about 600 patients, so a huge undertaking. And hopefully we'll have the answer to that in 5, 6, 7 years, who knows. And then finally, could we be a little bit more clever? The new guidelines for pneumonia from NICE have just come out, suggesting that in advanced pneumonia or severe pneumonia, we should be giving steroids. As I said at the start, my feeling is that pleural infection is a hugely inflammatory process. And there's massive upregulation of all these pro-inflammatory cytokines. So could we try steroids at some point in the treatment process? It's been done before in pediatrics, so just in 60 kids who had some sort of pleural effusion on their chest x-ray with pneumonia, and it reduced their time to recovery. It's also been done in adults. Gary Lee in Australia and Debbie Fitzgerald, they did this in 2022, but it was just a feasibility study. So they randomized 80 patients, 52 to Dex, 28 to placebo, and it didn't have any effect, but they randomized all comers. So you could have had simple pneumonic effusion that was never tapped, or frank pleural infection. Didn't see any effect, but I don't think that question is answered, especially with a relatively small study like that. So I think there would be room for a study of steroids in pleural infection as well. And then finally, something maybe a little bit more crazy is, could we be a little bit more targeted? So we noticed, one of my colleagues, Fergus Hamilton, who's a geneticist, as well as being an ID doctor, we're trying to publish this together. So we looked at this prospective observational cohort of pleural infection we've got. We looked at IL-6 levels in all these patients, which are completely off the scale, by the way, compared to in serum. So like 20 to 1,000-fold higher than you'll see in serum levels. So it is probably being produced by the pleura. And it correlates with effusion size on chest x-ray, it correlates with length of stay, it correlates with mortality, the IL-6 levels in the pleural fluid itself. Then he's also done a 2-sample Mendelian randomization. You get about 1,600 cases if you add all the large cohorts together, because pleural infection remains relatively uncommon. And for pneumonia, blocking IL-6, okay, is harmful. But that's pneumonia, all comers, even in pneumonia just diagnosed by your GP. We know that tocilizumab that blocks IL-6 is useful in COVID, but then that's the result for pleural empyema. So on the face of it, very protective in pleural infection. But you would, before we had COVID, using tocilizumab in patients with active infection was probably seen as fairly crazy. Using it in somebody with deep-seated infection, I still think you'd have a few eyebrows raised. So there's some work to be done to try and move the field forward. And finally, how can we prognosticate our patients better? Naj and Nick came up with the RAPID score, which essentially is a bit like the CURB-65 score for pneumonia, where you look at patients' urea, their age, the purulence of the fluid, where they got their infection and their albumin. And you can actually really accurately prognosticate these patients depending on their RAPID score, which is actually really helpful when talking to the patient about their survival and talking to the surgeons as well about whether you take them for surgery or not. That's the new BTS guidance, which just covers basically what we've talked about. And finally, a little bit of a plug. This came out in Lancet Respiratory. It says, respiratory research remains vastly underfunded at the moment, and especially in infection. So what we've done is we've set up, with the help of Charlotte, we've set up a James Lind priority setting partnership. So if you do have time, that's all over our Twitter as well, or you can scan that QR code. But thank you very much for listening.